First, I want to thank the organizers for inviting me to give this talk. It is a bit of a change for me. I think it's probably less data than I would normally show in one of my presentations. But after that wonderful presentation, I think this will give us some idea of where we may be and what we might be talking about 5 years from now when we're treating patients with some of these alternative delivery mechanisms. I'll mention I have no competing interests to disclose. I'll also say I'm not involved in the development of any of these products, and there are far more exciting products being developed than I can possibly cover in this amount of time. So if I fail to mention any, it's not for lack of importance, it's just probably that I didn't have access to good pictures or slides. So I borrowed this slide from my colleague, Courtney Fletcher, who kind of outlines, I think, a lot of the things that were really presented really nicely in the last presentation. So we know that long-acting injectables work. Now what do we need to do to make sure that they work in the best possible way? And I would kind of characterize this in a few different groupings. So first of all, we have to make sure that we can extend it to all populations, including children and adolescents. And I think that work is being done already. Of course, we're concerned about women throughout all stages of life and all conditions, which I'll come back to again at the end in proposing what we need to think about in developing these long-acting formulations. And then next, we have to work on optimizing the drug characteristics. So how can we optimize the frequency of injections? How can we optimize how much the injection volume is? And perhaps are there other routes of delivery that may be more beneficial or offer different alternatives for patients who may want different options? And then we're going to have general clinical management questions. So all of the questions that we have worked hard at addressing with oral therapy, we're going to have to also address with these new delivery techniques. So how are we going to manage both short and long-term adverse effects if you can't remove a product? How are we going to manage drug interactions that may require a dosage adjustment that we previously were able to just do with an additional pill? And then finally is what was described very nicely, sort of the implications of the long drug detection period over a long PK tail. But what I think is encouraging with this is that we can learn from other disease states and other conditions that are ahead of us in this particular area. And so I highlighted just a few things here that I think we can learn from our psychiatric colleagues who have been using long-acting injectables for a long period of time. So I will say up front, I'm going to slaughter these drug names, and they're not drugs that I know a lot about, but I think they offer some unique opportunities. So it's important when we are treating patients with severe psychiatric conditions, particularly schizophrenia, that when they get discharged from the hospital, we know that we can give a long-acting injectable to ensure that they remain on therapy. So here's an example of a couple different products of paliperidone. So this is a antipsychotic that allows you to transition from an oral therapy or other long-acting therapies. There's one formulation that is given once monthly for a period of time to get the patient up to the desired exposure as well as effect. And then once that patient has been on that product for at least 4 months, they're then able to transition to another longer acting suspension that only has to be given every 3 months. It allows for dose optimization, variation in dosing based on effects, and then it allows patients to go to less frequent dosing, which is going to be helpful for our patient population. Next is Aripiprazole, which I'm sure I'm saying wrong, which is another antipsychotic that is available in a oral product as well as a long-acting injectable. Previously with this product, patients would have to take the oral medication for 21 days, overlapping with the long-acting injectable in order to allow the injectable to reach adequate concentrations. So what they have now is they have, so that injectable is the Aristada on this slide. So that was a micron particle size injection. What they discovered is if you could get that into a smaller particle size, so take it to a nano formulation, the drug would dissolve much faster and then allow it to get released into the system at a much faster rate, reaching appropriate concentrations much faster. So now this is available to give a single oral dose on day 1, and then an injection of both the nano and the micro on day 1. That nano formula gets the drug concentrations where it needs to be within the first few days, and then by the time that wears off, the microparticle is there to carry it forward. What's also exciting about this is it helps give us some insight into what we might do with missed doses or what we might do with potentially drug interactions. So again, you'll notice that there's lots of different dosing that's available for these products. It's not a one-size-fits-all. And they've come up with a really nice supplementation plan where if a patient doesn't return for a visit, they're able to use the shorter-acting injectable to kind of boost them up and get them back where we want to be. So I think we can learn a lot from the drug development that's happened in this area, and it really gives me a lot of encouragement that I think this is only going to help us expand the use of long-acting injectables for our patients as well. So with that, I'll shift to what are some of the potential technologies for delivery outside of long-acting injectables. And for this, I'm going to try to focus on what might be possible for a fully suppressive antiretroviral regimen, as well as for prevention. So there's lots of different products, and I think the key thing that this represents is that it's really moving us towards an era where we're going to have a lot of different options for our patients to promote their choice, promote their ability to have a convenient formulation that works for them, and then most important, simplify the adherence and really help them be able to do the best that they can with the product available. So I'm a pharmacist, so I have to step back and just remind us what sort of a good product formulation or what a good product may look like for a long-acting agent. So as I think was described nicely for cabotegravir, we're looking for a medication that on general requires a fairly low daily total dose with a fairly long half-life, which could then help allow less drug to be required to be used over a long period of time. And then we want a really highly potent drug. So drugs that we're looking for drug concentrations in the picogram or nanogram range, maybe microgram range, to allow us to be able to really optimize that therapy. So there's a few things we can do to adjust the medications in order to help them really achieve these characteristics, but it always helps if you can start with these drugs in the first place. I'll cover some of these today, and those include changing the characteristics of the drug by making it into a nano formulation, creating a prodrug, or of course, adding a different delivery device. So I'm going to start off with the drug or a drug delivery device that by definition was made to be used for women, the vaginal ring delivery system. So I could have probably filled the entire time with talking about vaginal rings, but I think it's probably an area that most of you are familiar with in the area of PrEP. So I'll just mention what's sort of new and emerging in this area. So we know from data that's been presented with the dapivirine ring that it works best when patients are able to use it consistently. And one of the things that I think is exciting in this area is they're looking for ways to help make the vaginal ring more acceptable and interesting to women at risk for both HIV as well as pregnancy. So is there a possibility that combining the contraceptive ability with HIV prevention, a way to really optimize this particular strategy together? And these are interesting. So to my knowledge, there is a dapivirine levonorgestrel combination product and a tenofovir levonorgestrel combination product that's probably the furthest along in the process. And they use lots of different technologies, but in a sense, they're all vaginal ring products. And it really allows for very concentrated local administration of the antiretroviral regimen or antiretroviral medication to prevent HIV transmission. And then hormones, as we know from the use of vaginal rings for contraception or hormone replacement therapy, are really absorbed very well from the vaginal tract. So giving the hormone by a vaginal ring allows the concentration to reach concentrations adequate to suppress ovulation, as well as change the vaginal milieu to prevent pregnancy. So I think there's going to be some exciting things coming out in this particular area related to PrEP. But now I want to switch over to maybe some other products that have exciting applications for PrEP, but in theory could also have some great applications for a fully suppressive antiretroviral regimen. So the first product I wanted to talk about is implantable devices. So I think implants we're very familiar with because we use them for contraception. As far as their use as a long-acting product, I think they have several advantages and disadvantages. And I think I would argue that the advantages really address a lot of that first slide that I showed very well. So we know that they can be removable at any time, so either at the end of a treatment regimen or should an adverse effect occur, it's something that you can go in and remove the drug relatively quickly. They also have the ability to provide therapy for many years with a single administration. So, for example, the Nexplanon product is approved for use for 3 years. There's other progestin-containing implants that are available for 5 years of use. So it's a possibility to have really, truly long-acting administration. And then we have the ability to palpate them under the skin. So patients are able to feel it and know that it's there and know that it's working for them. There are some disadvantages that may require consideration, such as a medical procedure to insert them, but that's been very easily overcome in settings where we're giving subdermal implants for contraception. And it does have a slightly more complicated regulatory environment because you're implanting both a device as well as a drug. But using products that are already available or known offers us pathways to overcome those. So what are the emerging implants that are coming out? We do know of a biodegradable TAF implant that is, I believe, approaching preclinical, or it's in preclinical studies and should be progressing to early clinical development soon. This was a presentation earlier this year, or late 2018, that looked at a biodegradable TAF implant. It was really informed by user preference. So the goal is to have 2 rods for a period of use of 1 year. It's a biodegradable product, so once it's placed, the patient doesn't have to return to have it removed if she doesn't want to. And it's a flexible product, so it doesn't have a discomfort under the skin. And then importantly, it uses an applicator that's widely available for contraceptive implants to make it an easy subcutaneous administration. So overall, what the early PK data show us is from the blue and the green dots, we see sort of the active drug, so the tenofovir or intracellular tenofovir, and all of them maintain concentrations well above what we would hope to see to prevent the transmission of HIV. So this is an exciting potential development on the horizon. Another type of implant that is under development is using some of our older product formulations, so TDF plus FTC, and they're developing a refillable implant. So this would be more along the lines of what patients with diabetes can use for an implant. So you can take the drug, administer it over a period of time, and then refill the product when needed, which offers some unique opportunities if you have potentially drug interactions, you have to increase the dose or overcome the dose in some way. Again, early in development, but it demonstrates that concentrations could be maintained using this particular device over a period of time. I thought this was particularly interesting because it offers a way to administer at least 2 of our 3 medications using different devices, and kind of represents the possibility of perhaps a day in the future where you could put in 3 different implant rods or devices to allow for adequate antiretroviral therapy over time. And then I also want to mention a new NRTI on the horizon. So this is a Merck product, EFDA. This is a product that's in development both as an oral agent, and then it has a lot of the characteristics that I mentioned. So it requires a low total daily dose, has a long half-life, and is very potent. And they've demonstrated in a solid formulation and an injectable in animal models that it can maintain very good concentrations over time from an injectable. And they've moved that information into an implant. It's particularly useful because Merck is the developer of the Nexplanon or Implanon contraceptive implant. So it's nice from a regulatory perspective that they have that product availability and that device that's already gone through the production and the FDA procedures. So this is a recent publication that looked at both bioerodible, which I presume to be dissolvable, or non-erodible implants that show effective concentrations over 6 months of time. And they did simulation work with this to compare it to their prevention studies with a weekly oral tablet, and demonstrate with the green line that implant did maintain concentrations well above or a nice stable concentration to achieve the prevention doses required. And then a new kind of different implant that was sort of new to me as I started looking at this is an interesting way to take a injection that actually starts as a solution. So this is a dolutegravir solution that's co-formulated with polymers. You inject it just subcutaneously, and this is a quote from the article. Within a few hours or days, it forms a globule, which apparently is also an implant, that is actually kind of this P-shaped little device that can be removed as well. So it starts out as a liquid, and then once it gets into the body, it forms this solid particle. And again, it allows for that really nice, stable release of drug. And then what I think is nice from this particular graph on the right, it gives you a demonstration of how if you remove the implant, the drug concentrations fall relatively quickly, removing some of the concerns that we've talked about of that prolonged PK tail. So I think in total, all of these areas and implants give us hope for something that could be a very long-term product over a period of time, and perhaps with multiple implants, we could achieve an effective antiretroviral regimen someday in the future. So with that, I'm going to move just briefly into long-acting oral products. And I'll take a moment here to mention that there is so much work happening in the area of nanomedicine, so nano formulation of existing drug products as well as new drug products to really optimize their delivery, that I couldn't go into all of those. So I want to at least acknowledge the huge amount of work that's going into this space and just highlight some of the goals of that nano medication. So first of all, it can take the nano formulation of an existing product, can take a product that is needed to be given daily, and through nano formulation can increase the half-life of the medication so that it can be given in a smaller daily dose or less frequent dosing. They can also co-formulate the medication to target specific areas of the body. So this is particularly of interest for reservoir sites, where you could have sort of programmable drug, so to speak, that will really target the areas of the body that we sometimes have a hard time penetrating with our drugs. And then, as I mentioned, you could also go into the more long-acting nanoformulation. And these nanoformulations are being developed across the range, both for oral as well as injectable products. I just wanted to mention one particular oral drug delivery system that I think is of particular interest. So this is a novel formulation where you take as the stomach picture shows, it looks like just a regular pill. Once you swallow the pill, it sort of opens up into this 6-arm starfish-shaped device, which then actually stays in the stomach for a period of time to release the medications. This has been, the data that I'm aware of with this has been done in a pig model. The nice thing about this is it has all of these different arms that can be programmed with different medications. So each arm can have a different medication, or you can use 3 arms for one medication, 2 arms for another, 1 arm for a final. So it allows you to really program how much of each drug is available and released over time. And as I mentioned, I think this has only been done sort of in a proof of concept fashion in a pig model. The top line, they did look at some interesting drugs. So they combined dolutegravir, rilpivirine, and cabotegravir. The top row there indicates what the drug would look like given as a regular oral pill. And then the bottom shows the sustained release of this 6-arm star product. So again, very early in development, but I think shows what innovative strategies are potentially emerging. Moving next to patches. So patches are something that we use for lots of different products, but I'm going to show what I think is a more interesting patch. So this is a micro needle patch, which can sometimes be used for delivering, to my knowledge, I think vaccines are probably the most common. So this is a technology that was developed at Queen's University. Essentially, the patch has these needles that are attached to it that are made out of both drug as well as polymers. When the patch is applied, it actually changes color and shows you how hard you need to push to make the patch release the drug. And then as this lovely diagram shows, essentially when you put it on, the body dissolves the patch. It forms this intradermal area of drug delivery that can then be developed over time or released over time. And I know that this, in the last 6 months or so, has a new USAID-supported collaboration to be evaluated for cabotegravir provided PrEP products. So with that sort of really broad look at what may be on the horizon, I think just some final or big picture thoughts on novel antiretroviral drug delivery mechanisms, both some needs as well as opportunities. So I think it does have the opportunity to provide us an option for many long-acting combination drug delivery devices. We can use that both for existing drugs by optimizing either their release through nanoformulation or through some of these devices, but there's also new drugs on the horizon that will also give us some opportunities in this space. As I mentioned, there are really exciting technologies within nanoformulations that can help us target the drug supply to the areas of the body that we are not always able to target very well. And then there's areas that we need to work on further developing related to pediatric and adolescent administration of these products. And I think what's been interesting to me as I read about these developments, I think there's a real mind towards making sure that all of what we're doing is really truly scalable, so that if we develop these technologies, they're technologies that can be built up and delivered throughout the world, not just to areas of the world where they have the best insurance providers. So I think that is an encouraging perspective. And then I want to take a look at how these may translate to women. So in thinking about this, I thought about it in the context of contraception, because a lot of the formulations I just described are really readily available for provision of contraception as well. So I think what we've learned from contraception is if you do have increased choice of contraception that you can provide your patients, there is more likely to be an increase in the uptake of contraceptive, because those patients are able to choose what's truly right for them in their particular circumstances at that time. Their desires change over time, and we have to be willing to accommodate that. And so the more and more different drug delivery devices that are available for antiretroviral therapy may also be an opportunity to improve adherence for patients who struggle with our usual oral daily doses. It's also important to note that it may vary by region, or it may vary by cultural background. I think we've seen that with the vaginal ring development. Some patients really want them, some patients really don't. And I think acknowledging that and giving them a breadth of options is really our best possibility. And then the last thing I thought about was I think one thing is to make sure that we are coupling all of this new drug development with proper education, both for our healthcare providers as well as patient-appropriate education, so that they can really be informed about what these methods are, what are the benefits, and what are the risks. And again, I think we learned from our contraceptive colleagues that as you can provide better education for patients about contraceptive risks and benefits, and then also remove some of the financial barriers, that helps them make the best possible choice for their circumstance. So that same slide, sort of thinking with a focus on women, and I think these are really complementary to the last presentation and what was presented there, with much more actual data versus animal data. I think we have to be sure as we're developing these products is whether or not there's a difference in drug dosing, and is that apply to during pregnancy or during just related to gender in general. We also have to consider if there are important drug interactions for women who are at risk for or living with HIV. And not only are there interactions, but how do we manage those interactions? So those of you who know me know that I can't leave this presentation without at least mentioning the interactions with contraceptive therapies. And I think we have to be able to offer our patients the best options to manage those drug interactions, not just tell them that there are drug interactions. And then we've talked a little bit about pregnancy. Are they going to be safe and effective during pregnancy? If we know that they are going to be unsafe, can they quickly be discontinued and removed? And if they are safe, can they maintain adequate exposure to help prevent transmission to the baby and protect the mom during pregnancy? I think using some of the drugs that we already have data with in oral therapies as we move to some of these novel technologies will help improve this access much more quickly because we'll have the safety data. Then it just becomes answering the questions about the change in the drug delivery method. And then I decided to pose a few what may appear to be simple, but I recognize are not necessarily very simple solutions to addressing some of these questions. So I think we have to start early. We have to start thinking about this when we're doing animal studies. It's interesting to look at animal studies, and some do a really conscientious job of evaluating differences related to gender. So some of the implant studies actually looked at concentrations in the female genital tract of the rodents that were studied. Others don't mention whether the animals were male or female. So it's something that we could start early to see if there's anything that we can start addressing earlier on. We have to acknowledge that we have these questions early on in the clinical development process and the early clinical evaluations so that we can enroll a very diverse, reflective patient population. And I think a lot of work has gone into largely probably due to advocacy from people in this room, to increasing the participation of women in those early clinical trials and removing barriers to allow women to participate in those early clinical trials. And then finally, we have to ask the right questions up front about what potential challenges we may encounter for women versus men, or really any gender. And then we have to present those findings at these conferences really stratified by sex so that we can see if there are any differences there. So I'm hoping that will generate some discussion. I have a feeling I'm probably preaching to the choir in this room. I just wanted to close with my acknowledgement slide. There are far too many people to mention, but I wanted to at least mention the LEAP investigators, so the long-acting extended-release antiretroviral resource program. It's an NIH-sponsored program led by Charlie Flexner. It has a wealth of information. The website is great. It does a great job of maintaining a list of resources of emerging technologies, and it's really a great go-to. And then my usual tribe, who always help me and support me in putting together these presentations. So thank you very much.